So we'll start with a little talk with some of the stuff that I found a bit confusing with the pulmonary stuff. All right, so if you remember from whenever you did pulmonary the first time, term one. So we basically break things down into obstructive versus restrictive, right? So COPDs are obstructive, and all those, irritating diseases that, asbestosis or any sort of autoimmune disease, those tend to be those restrictive or fibrotic diseases. So there are a couple of things to get into there, but what I want to talk about first is this idea of diffusion. So some of this confused me for a while, so it took a little bit. So if we look, well, no, that's terrible. Hold on one second. Let's just call this an alveoli, right? And then we're going to have our blood vessel down here. Now, typically, when you talk about oxygen and carbon dioxide, we talk about perfusion limited, right? So that's going to rely on the amount of blood flow that goes through, not necessarily the ventilation. What they talk about in regards to the diffusion is this diffusion limited carbon monoxide. Okay, so we're going to get to that in a second. The first thing I want to talk about is the idea of diffusion and this idea that we obviously have to cross this barrier. So this is the main point that you want to get across, is that this barrier is where all of the oxygen is going to get into the blood, all the carbon dioxide is going to get out. So when we talk about these different diseases, obstructive versus restrictive, this is a major component of it. So let's start off with the obstructive things. Now, when you talk about COPD, particularly emphysema, there's not a problem with this diffusion gradient, right? So they talk about with emphysema, they talk about these pink puffers, right? They're pink because they're oxygenated, right? So they don't have a problem with this diffusion component. It's just the idea that the dynamics of the lungs and the architecture of their chest that doesn't let them get the carbon dioxide out, right? So that's the problem. So it's not really a diffusion component that comes into play. Now with bronchitis, it's also obstructive, and they call them the blue bloaters. Now, the reason they're blue is because they have mucus plugs in there, but technically it's really not this diffusion component that comes in to play. But when you talk about these restrictive diseases, so let me back up. So again, when I say these obstructive diseases, it's not exactly the parenchyma or the actual the lung and the alveoli and this diffusion component. That's not really the problem. The problem is the fact that they have this barrel chest, and the outer aspects, the pressure that's forming on the outer aspects of the lung, and the outsides of the lung, that's causing the problem. Okay, but when you talk about these restrictive diseases, we're talking about fibrosis and stuff around this diffusion gradient. Okay, so you can think of these obstructive things as like a chest wall or an outer aspect of the lungs and a pressure problem, whereas the restrictive lung diseases come into this diffusion component. Okay, so the reason they use carbon monoxide here, you really don't need to know a lot about the testing and how they all do that, but the reason they use carbon monoxide is because it's dependent on this diffusion gradient. Okay, so they could use all those little tests they use with the carbon dioxide, and they could figure out because carbon monoxide is reliant on this diffusion gradient, they can use that to determine if there's some sort of problem getting getting air from the alveoli to the blood and vice versa. Okay, so that's a big component there. Now, people also get confused with this VQ mismatch and this whole idea of dead space. So let's start out with the dead space. Now, technically, if we had some sort of, remember, we're saying restrictive lung diseases, we're having a problem with diffusion. We've thickened this membrane here, so you're not able to diffuse the oxygen across. So what you actually did is you actually increased dead space, right? This right here would be your normal dead space, right? There's no actual, this is the conducting system. There's no actual oxygen exchange across it. Now, if we had some sort of restrictive lung disease, where the blood is not going, the air is not going to go through this diffusion gradient, we actually increased our dead space, right? Any portion of the lungs that's not going to have oxygen or diffusion going across it is considered dead space. So in essence, if there's any decrease in this diffusion capacity of carbon monoxide, we're saying we increase dead space, okay? So I want you to keep those two, I know this is a good bit of review, but I want you to keep those two separate. Now, another concept that was a bit tricky, let me clear this real quick. Let's see, so if we, this idea of this VQ mismatch, right? So when we talk about ventilation, it's ventilation over, sorry, it's a Q, not a P, and that's ventilation over perfusion. So one's gonna have to be the problem, right? Are you having problems getting air in, or you're having problems perfusing the lungs with blood? Either way, you're gonna have this mismatch. Now, one of the tricky things is if we look at kind of like a larger alveoli here, what I had confused for a while is this idea of shunts, right? Now, if you had some sort of mucus plug here, right, that's considered a shunt, okay? This is a shunt. I know that they talk about shunts in the heart, and you kind of think of the idea of shunting blood around as being a shunt, but when we talk about it in the lungs, the shunts are considered air blockages, okay? What I'm trying to say is that if the lung was clear and you had a pulmonary embolism, for instance, right? Yeah, well, let me put it over here, right? You had a pulmonary embolism, so blood cannot go across here. This is not considered a shunt, okay? It's considered a pulmonary embolism. So anytime they talk about a shunt, they're talking about some sort of air blockage. So I had that confused for a while. So just keep that in mind. When you're in the lungs, the shunts are regarding to some sort of blockage in ventilation. Now, granted, if you did have something, shunt, some sort of air shunt, say some sort of mucus plug or foreign body or whatever, right here, what happened to your dead space, right? You actually technically like decreased it, right? Because this area would have been dead space too before you get to the diffusion component. So technically you decreased it. Okay, I haven't seen any questions like that, but it just gets the point across that this is the idea of a shunt. Now, some other terminology you may come across is is this idea of this VQ mismatch. So whenever, if you do the math, you can figure out that if there's a problem ventilating the lungs, say you have some sort of mucus plug or whatever, then the numerator is going to go down. Now your perfusion's fine. So anytime they say the VQ is approaching 0, that means you had a problem in the numerator, right? So you have a problem ventilating the lungs for whatever reason. Now, if they say that if you have a problem perfusing the lungs, some sort of perfusion problem, if there's some sort of heart defect or whatever, and you're not perfusing the lungs properly, some sort of shock or anything like that, then the VQ is going to approach infinity, right? Because the denominator is going down. Okay, so if you ever see those in the questions, just put V over Q and just work it out in your head what's going on. Okay, I think that's all I wanted to say for that for now. The main thing was the idea that I thought a pulmonary embolism was considered a shunt, because it does, you're shunting air away from that area, but it's not in the lungs. The shunt is regarding air blockages. Okay, so we'll go through my notes. I'm not sure if I posted these up, but I will post all my notes up on my drive a little later. Okay, so, right, of course, you always have to know this. You have to do the math there. We took our exam on this a couple of weeks ago. We had a couple questions doing this. You have to know it. You have to know how to figure out. You'll probably have to use 2 equations to work out and then add those together to get the number. So make sure you're able to do these backwards and forwards. All right. And you know this too, right? Our type 2 pneumocytes are super important. That's going to make our surfactant around what would we say, like 24 weeks, around that time frame. If for some reason the child needs to be delivered prematurely, you can give the mother glucocorticoids, and that will help to speed up the process of making surfactant. So that's a good thing to know there. And then the type 1 pneumocystis just basically make that diffusion barrier, okay? You know this, I think in term 1, they had that nice little graph that showed you like where everything goes, the cartilage, how far the cartilage goes, how far the goblet cells go. Remember, you want the goblet cells up top, you want ciliated columnar epithelium up top, primarily just to sweep all of the excess stuff out of the way. And then of course it's gonna be, you want cartilage there because you don't want it to collapse, okay? Let's see. Now, the only thing atelectasis is a downstream collapse, okay? So if you have some sort of like, if you think of the air dynamics, if you have some sort of plug there, then it'll tend to collapse downstream of that. So any sort of atelectasis, so when you think of chronic bronchitis, that's a big one. Any sort of things, you can get multiple types of atelectasis. So if there's an obstruction this way, this is the resorption, you need to know these definitions. You could see it there. So if it's there, it kind of has this pulling effect, this negative pressure. So it causes atelectasis, you know, it would start here and end up pulling the whole lung down like that. And y'all are getting into the what do you call it? These small groups where y'all are doing things. So you need to get some of these words down, this tactile epiphragmatus, the 99 thing, all that. But truthfully, you won't, I don't think any of us will really appreciate all these different sounds like crepitus and all that until we actually hear it in the hospital. So just kind of make sure you understand the words, and it maybe not what it sounds like, but associate the words with what disease pattern you have, like rails and crackles with pneumonia, stuff like that, and you'll be able to answer the questions. All right, then you have compression atelectasis. Remember, we talk about pneumothorax, right? Tension pneumothorax primarily are the bad ones. So if you have some sort of blunt trauma to the lung through the chest wall, you will get this compression, right? So opposed to the atelectasis coming from like a sucking effect from sort of blockage, you're getting this compression atelectasis from the outside. So of course we know this is classic. Trachea deviates away from that, right? Because all of that excess pressure, when you have that blunt force trauma here, the air gets in and it can't get out, right? So it's gonna keep compressing. It's gonna push this right lung all the way to the, to the other side. And it's going to make the trachea deviate. So got to get the patient to the ER, put a chest tube in, and try to get that air out. Okay, and then they have contraction atelectasis. This is what you see when those fibrotic diseases. Okay, you want to try to, they are potentially reversible. More often than not, you're just going to with medication or prevention of, a lot of times this is like occupational hazards. You're going to slow down the process, but technically it is reversible to a degree. Then neonatal atelectasis, we're talking about our deficiency in surfactant, right? The alveoli are the most downstream component of this complex. So if you don't have surfactant and those alveoli collapse, by definition, that's atelectasis. Okay, so, and that's what we see with RDS. I get y'all are getting to the point. Like it's, when I write my notes, I don't dive too deep into I won't write like all of this. Like I feel like everything's eosinophilic, I try to use buzzwords, like if they have, somebody's name, certain components to it. But if some word really sticks out that's specific to this disease, try to put it. But by no means do I like sit there, because I feel like a lot of these have a lot of crossover. So the thing about things that cross over, it's hard to test. So you're looking for very specific differences in these disease patterns. But obviously y'all are aware of that by now. Okay, yeah, but so a perfect example, like ground glass appearance on X-ray, like that's something that they could put in the stem of a question, and then you should be able to notice that, even though that's kind of like that fried egg appearance. Everything's fried egg, so it comes up a lot. All right, so then we talk about acute lung injury. You see this abrupt onset, hypoxemia. So that's hypoxia is difficulty getting blood in, or lack of blood coming in, right, into your lungs. Hypoxemia is low oxygenation in your actual blood. Okay, so that's the whole point. Hypoxia is one thing, but if you don't have that diffusion, you're going to get hypoxemia. So acute lung injury is one of those things that can be very bad very quickly. So you need to try to get the patient in a situation that's going to help to alleviate that. Problem is, once the macrophages get around and you start having fibrosis, that's problematic. Fibrosis is, scar tissue, right? So it's kind of hard to fix that after that point. And keep in mind, I didn't mention this before, but these type 2 pneumocytes also help in the reparative process of the lungs as well too. So they're pretty dynamic of a cell type. Let's see. Yeah, so, okay. Yeah, and when we talk about different fluids, right, this isn't exactly on the page, but it reminds me, anything that has exudate has stuff in it, right? Transidate, when they talk about that sort of diffusion, if you have pleuritis or something like that, transidate is basically just water. Exudate means there's stuff in it, there's neutrophils and stuff like that. So keep that in mind, because that'll kind of tell you what's going on in the process. And hyaline membranes, when they form, that's kind of that beginning process of fibrosis, right? And you can see that here, and this just goes through the process, the acute phase, these hyaline membranes are forming, then you're like, we need to stop it now before the fibrosis gets beyond the point of repair. So these type 2 pneumocytes kind of come in and do their job. All right. Cool, right, all right. Let's see, what's this about? All right, so obstructive. What's the big thing about obstructive? Remember, your FEV1 to FVC ratio is gonna go down. This is like a dead giveaway on the FVC. No, it's not FVC. Forced vital capacity. Yeah, FVC1 over. What is it? I should know this. We'll come across it. Does anybody, what is it off the top of your head? FVC, forced, shoot, we'll come across it.
FEV1 over FVC.
FEV, oh yes, forced expiratory volume in 1 second over forced vital capacity. Thank you so much. Now, the big thing in obstructive is, so remember, they don't have a problem getting the air in. It's just once it's in, everything collapses on itself. That endpoint pressure kind of moves down towards the alveoli and everything collapses. So then they can't get the air out, right? So technically, both of these values are going to decrease, but that forced expiratory volume in 1 second is going to decrease tremendously, right? Because that's the whole idea. They can't get the air out. So they have this this obstructing problem. They end up getting a barrel chest. Their functional reserve capacity, their residual volume goes up. So you need to keep this in mind, because in the questions, they will put, a lot of questions will put this. The FEV1 to FVC ratio is low, right? Meaning your numerator went down significantly more than your denominator. Okay, so that right then and there tells you that you have an obstructive problem. Okay, so you can throw all the restrictive stuff away. Now, the big one, remember, emphysema and bronchitis tend to go together. So it's like kind of like it seems like when they teach it, they kind of separate them. But if you're going to have emphysema and you're smoking, you're probably going to get bronchitis too. So let's talk about emphysema. So what ends up happening, and this is a good thing to know, is that emphysema is going to cause this centroacinar emphysema, right? This centroacinar problem. Whereas what you see in alpha-1 antitrypsin deficiency is this panacinar. We had a question like this on our last exam. Or maybe it was a practice question I came across, but I saw it recently, right? So they're differentiating the two. Now, how do you differentiate these? Well, besides this component being a little bit different, remember with alpha-1 antitrypsin deficiency, you're going to get cirrhosis of the liver too. They really need to tell you that, or you know what they do a lot of times? They'll give you an emphysema and they'll tell you that the liver lab values are normal. So right there, you can rule out alpha-1 antitrypsin, okay? So another thing, smoke rises, so you tend to get emphysema, the centroacinar emphysema in the upper lungs, and with alpha-1 antitrypsin, it tends to be in the lower lungs, okay? So remember, the idea of alpha-1 antitrypsin is that these neutrophils are going to produce elastase, and this alpha-1 antitrypsin is able to counteract this elastase. So that's the whole process. So if someone smokes that has alpha-1 antitrypsin, they can develop this emphysema in a couple of years of smoking, okay? So keep that in mind when you do this. Like I was saying, this antitrypsin helps to alpha-1 antitrypsin helps to counteract this elastase. Elastase is an enzyme that breaks down elastin, right? Keep it simple. So if you're breaking down elastin, you're really messing up that endpoint, the alveoli. Another thing that keeps coming up that we're seeing recently is this idea that, the acinus is really kind of, that's just to get the point across, right? So if this is normal, this is what you see in emphysema, okay? And the point I'm trying to get across is that you get decrease in diffusion in this situation, not because you have a problem here in this diffusion points, right? Or even here, it's because by breaking down these septal walls, right? By going to this process, you lose a ton of surface area. It's kind of like the microvilli in the GI tract, right? All those little villi add surface area, so you're able to absorb a lot of stuff. This normal process right here has a ton of surface area. So emphysema will break down these septal walls, so you lose a ton of surface area. Okay, so they're not able to properly diffuse oxygen across, but it's not necessarily the actual diffusion gradient, the transition. It's just the fact that you lose so much surface area. Let's see what else. Right, so look at this. This is all broken down. Like I was saying, this is, these septal walls are being broken down. You're losing a ton of surface area. You're losing elastin. You're not able to even contract, so you can't get the air back out. So it's a big problem. Hyperinflated lungs, you get that barrel chest formation. Again, pink puffers, right? Meaning they get oxygen in, they tend to not be able to get carbon dioxide out. Remember, if you can take it to another level, the carbon dioxide that they can't get out acts as an acid. When we do those, respiratory acidosis type problems, if you can't get carbon dioxide out, you're holding on to acid, so you end up with respiratory acidosis. Okay, and as you learned in cardio, some of these problems, anytime you have some sort of pulmonary pathology, pulmonary hypertension that leads backwards to right heart failure, it's going to be called cor pulmonale. So in other words, we're saying that the right heart is having to press against such a high afterload because of this pulmonary pathology, because of this pulmonary hypertension, and so you develop right heart failure. All right, and again, the FEV1 is significantly lower than the forced vital capacity, okay? And again, we see respiratory acidosis in these patients just because, again, they're pink, they're fine with the oxygenation, just they can't get this carbon dioxide out. All right, so bronchitis, again, in real life, you really don't, they really don't separate these things. They go together, but when we talk about bronchitis, we're talking about just a ton of mucus buildup, hypersecretion of mucus. You can get mucus plugs. The big thing, and this is a dead giveaway in these questions, they really have to give you these numbers. It's like back when you did all of those psychiatric disorders, they got to give you the numbers. So as soon as they start throwing numbers at you, you want to start thinking of bronchitis. That's the one off the top of my head in the pulmonary system that they really have to give it to you. So 3 months over 2 consecutive years. That would, before they can technically have chronic bronchitis. Okay, let's see what else. And look at this. Look at all this goblet cells that form. All this goblet cells can form excess mucus. A big thing that comes up, this Reed index is important. Anytime you see that, it's directly correlating to bronchitis, okay? So I think, okay, this is it. This is that Reed index. All they're saying is that the Reed index goes up because this thickness of the layer goes up. And it basically makes sense because to make more mucus, you have to have more gland. Let me go back one slide, make sure I covered it. And it can even lead to squamous metaplasia due to irritation. I don't know how high yield that is, but yeah, so anytime that Reed index goes up, you're adding mucus glands to the three layers. All right, and then again, they're considered these blue bloaters, which it's still obstructive. They still can't get air out, but the fact that they have so much mucus, it really does interfere with their ability to get proper oxygenation. So if you were going to define emphysema, you would call it more of a hypercapnic problem. A hypercapnia, you can't get the carbon dioxide out. These patients will have hypercapnia. They can't get the air out, but they'll also have low oxygen. They'll have hypoxemia as well, just because those mucus plugs work both ways. You can't really get air in, you can't get air out. Then they collapse. You can get atelectasis with this as well, just with these plugs that form. Okay, so keep that in mind. But again, in real life, it kind of all goes together. I started this slide. I'm not a big chart person, but when it comes to stuff like this, like these are super important things that happen all the time in the States. So you can keep it straight with stuff like that. Right, but if you really just remember pink puffers and blue bloaters, you just work it out in your head pretty well. Cool, next. Asthma and bronchiectasis. Okay. Yeah. Okay, bronchial asthma. Typically, we talk about this as some sort of allergy response, right? Atopic, some sort of sensitization. You're thinking of IgEs being very high with this. So again, I start this one. This is a good way to differentiate. So IgE mediated, which by definition is a type 1 response. It's that immediate response, IgE mediated. Childhood, of course, Whelan flare reaction on skin test, allergic rhinitis, atopic eczema. Typically, when you see somebody that has some sort of autoimmune problem, you can have autoimmune problems that coexist. Okay, so eczema a lot of times goes along with atopic asthma. Then you could also have non-atopic. We don't talk about this one as much as the normal one, but this is some sort of post-viral problem. So it's not related to some sort of hypersensitivity. So in general, when you think of asthma, we're thinking about this extrinsic atopic problem. These got red because I think they're super important, right? So IL-4 is IgE. I think, what is the thing in first aid? Hot T-bone steak, right? So 4 is the E in steak. If you don't know what I'm talking about, go look at the immunology section. That's one of the things that I keep in the back of my head, that hot T-bone steak, to keep these interleukins straight in my head. IL-5 is eosinophils, even though honestly these really go together. So IL-4 and IL-5 kind of go together. IgE and eosinophils, E and E kind of go together. And then IL-13, not super important, but it does help with mucus production. Okay, and again, mast cells as well kind of work like, they'll degranulate, so they act as allergic response as well, sort of like eosinophils. All right. Right, and then when we talk about this non-atopic, even most of the time they talk about it as viral, but any sort of problematic, you don't necessarily have to be allergic to this stuff, but this stuff is so toxic to the lung architecture, you're going to get this chronic bronchoconstriction there. And then some people have aspirin sensitivity asthma as well. The big thing that they talk about with this is these nasal polyps, right? So they will talk about someone that has aspirin sensitivity, and they'll say when they also have these nasal polyps. So I would make note of that. And of course, this bronchoconstriction is a leukotriene response. So they have certain medications that block the process of making leukotrienes and leukotriene receptors. I don't remember them off the top of my head, but Xylutin or something like that. So yeah. And then of course, any sort of occupational hazard kind of works on the same level as this non-atopic asthma that can form. The thing about the occupational one is that it tends to develop after repeated exposure. So it's like your body eventually ends up getting a severe reaction to this. It just takes time. Yeah, red for sure here. These are some of those things like, I may not even, going into the exam, I may not even be able to recite what these actually are, but if I saw these words, I could immediately be like, okay, they must be talking about asthma, right? So, these are sort of the things that tend to pop up. Now, that's not necessarily ideal, because some of the questions we're getting now on the UWorld stuff, they'll just explain these things and they won't give you the name of them. So, you know, it's a give and take, just kind of like try to balance it out. Some of the more important things like asthma, maybe it is good to know how to, you know, these definitions, but as you know by now, it gets very cumbersome over time. Big thing here, you do get hypertrophy or hyperplasia of these muscles, this bronchoconstriction over time. And also you do get glandular metaplasia. Now, don't get this confused. If you see this and you're like, oh, they must be talking about bronchitis, not necessarily, right? So you do get hypertrophy of the glands in bronchitis, and as well, you can get these submucosal and goblet cells forming. So it is similar. So if you see the goblet cells, don't just jump on bronchitis. Remember, these asthmatics have that issue as well. And then, of course, status asthmatic is a severe asthma attack that's not responding to standard treatment. They need to be in the hospital quickly and probably be put on a ventilator. Okay, right, again, those. All right, so bronchiectasis, it's more of a problem with the larger bronchi, right? So this is the destruction of the smooth muscle. So you get bronchiolar or bronchiolar dilation. So after time, eventually, for whatever reason, you end up getting this dilation. So it goes into here, tumor-formed body. Things like cystic fibrosis can lead to it. So it's like this chronic issue with being able to transmit air, get air out. This increase in pressure kind of makes the bronchi dilated and the bronchioles as well. So that's all you really need to know about that. Some of the organisms that can do that could lead to some sorts of pneumonias and stuff. But it's usually, the way I think of it is this prolonged problem that keeps going with this increased pressure. So eventually you're going to get dilation to help to compensate and help to, you know, keep everything from collapsing down. All right, and you can see this with cystic fibrosis. You can see all of these mucus plugs that form. Again, you know by now how cystic fibrosis works, but the problem is if you don't have water, you're going to get mucus buildup. So you can see all that here that forms. Let's see. Okay. Lead to hemoptysis, obstructive respiratory insufficiency. Okay, so right. And then y'all know about cartaginers by now, sinus invertices, all of the organs are on the other side. But if you remember that this is a primary ciliary dyskinesia. So anything that has cilia that needs to work is messed up. So you can't sweep the lungs out. They're prone to pneumonias. They get infertility because the sperm can't swim, things like that. I did look up, I was like, why are their organs backwards? Apparently during embryology, the cilia play a large part in dictating where the organs go to which side. So that's why apparently that sometimes their organs are on the other side. And then of course, sinusitis, you have cilia in your nose as well. So recurrent infections, of course, this recurrent infection can lead to this bronchiectasis, this dilation of the bronchi. But it's pretty straightforward when you give you this. We did have a question on our last exam. They gave us cartaginers and didn't mention the organs were on the other side. So don't just rely on that to be one of, to give it away. Okay, so we move on to the restrictive lung disease. So when you versus the obstructive, when you're thinking of the outer aspects of the lungs, this pressure gradient, this dynamic, this atelectasis that forms. With restrictive, you're really talking about the inner workings of the lung, this parenchymal lining, this diffusion gradient. So it's really this chronic fibrosis that happens. And whereas with obstructive, you can't get air in, you can't get air out. You're trying to figure out just the dynamics there. This is a problem diffusing oxygen across. So it's very much nuanced in that degree, right? And then we talked about this before. So alveolitis doesn't sound like a good thing. If the alveoli are inflamed or infected, then you're not going to be able to diffuse air across, leading to dyspnea, hypoxia, ventilation perfusion mismatch, right? Because you can't get it across. And then, of course, it could lead to pulmonary hypertension or cor pulmonale, right? And think about that with pulmonary hypertension. If you had this area of the lung that is not being diffused properly, you have to shunt a lot more blood to a different, I say shunt, I shouldn't say shunt. You have to direct a lot more blood to a different area of the lung. So if that's the case, and you're trying hard to properly oxygenate the body, that could lead to pulmonary hypertension. Okay, so with that, of course, can lead to right heart failure as well. Okay, so a big thing here is that the FEV1 and FVC ratio are going to go down pretty much proportionally. Okay, now the problem with restrictive is that with this fibrosis of the parenchyma, of the lining of the lung and the alveoli, you can't properly expand if everything's fibrosed, right? So the air you can't expand it, so you can't get air in. So with obstructive problems, you can't get air out. With restrictive, you can't get air in. So if there's no air in, your numerator is going to go down, but you're not starting with a lot of air to begin with, right? So your forced vital capacity overall is going to go down. So you can think of these going down together, even increase, but I just remember normal. And like we talked about before, this diffusion limited carbon monoxide is going to go down. What that means is there's literally a problem in that diffusion gradient, that little area where oxygen and carbon dioxide are crossing from the blood to the alveoli. Okay, so that's a big thing there. That's how you differentiate it. Whenever I do these, that's the first thing I do. Is it obstructive or is it restrictive? And then I go from there. Okay, let's see what else. And right, so when we look at these different fibrotic diseases, don't get overwhelmed with this. A lot of these are very similar in their presentation. So you kind of just need to know the basics for how this works. Give me 1 second, I need to, computer's going down. So a lot of these have a very similar presentation. So you don't need to dive too deep into this, just kind of have, a nice definition for like what goes with what. So idiopathic interstitial pneumonia, this progressive interstitial pulmonary fibrosis that leads to respiratory failure. Being idiopathic, it's a primary problem, which means it generally is going to happen with genetically predisposed individuals, right? So I believe, so that, as it states here, that the process is these people aren't able to repair properly. So it's a primary problem with the repair process. If you can't repair, you're going to end up with fibrosis. Then again, a good thing to remember is this cobblestone appearance, and definitely these honeycomb cysts. You should, hopefully they give us a picture. Maybe look up a CT scan of this honeycomb cyst. Once you see a picture of it, you won't forget it. But the point is that when you look at it, you can see that, when you look at a normal, a normal CT scan, and you see the lung markings, right? This honeycomb cyst, these lung markings go all the way through. It literally looks like a beehive with these honeycombs, which means, and you shouldn't see that all the way through the lungs. You should just see it around the hilum. But when you see these lung markings all the way through the lungs, you want to think of some sort of restrictive problem. If it's a honeycomb pattern, it's usually this idiopathic pulmonary fibrosis or interstitial fibrosis. So you can see this honeycomb change. I think the CT scans, if you look at an axial section, it does a lot more justice to this. Right, and as you would expect, if there's a diffusion problem, you're going to get cyanosis. You're going to lead to right heart failure, and then clubbing of the fingers just is indicative of cyanosis. So you get like little bulging of the tips of the fingers. That's indicative of peripheral cyanosis. So anytime you see that, you can think of that. Right, so perfect. You see this, you can identify it. All right. Now I think we get into all the confusing ones. Yeah. Okay, non-specific. It says like this chicken wire appearance doesn't have this honeycomb change like you would see in the original one, the idiopathic one, but you get a fibrosis or a cellular or a fibrosing variant here. You could see that some respond to steroids. Sorry, I know I'm reading the slides. These are so similar to me. I literally use buzzwords to remember these, like the stuff that's in red. So yeah, so this cryptogenic, you can see this patchy subpleural or peribronchial areas responds to steroids. So you know it's some sort of inflammatory process underlying it, but here you won't see this honeycomb appearance. And right, organizing pneumonia. So again, it may be worth just, taking a piece of paper and just like writing these out in their different categories, just so you can keep these straight. And then collagen vascular diseases, anything like this, anytime you increase the collagen, you can affect the ability to diffuse oxygen across. Now, pneumoconiosis, it's important to know what exactly they're talking about. So coal dust, silica, and then asbestos, as you know, leads to mesothelioma. But these are, a lot of times, these are occupational hazards as well. You can see that. Yeah, and especially with asbestosis, it may not show up for like 40 years after you're exposed to it. And then some of these little explanatory or descriptive words are going to be important just to differentiate these on the exam. Again, because the clinical features, they're all going to present with cyanosis and clubbing and stuff like that, and dyspnea. So you really just need to focus on what could have caused it. Was it some sort of insult by some sort of occupational hazard, or what is it, some sort of problem with their reparative ability, as in the idiopathic one. So that's going to be important. And right, the reason asbestos is so important, because it was so prominent back in the day, in the 60s and 70s, that they used it for everything. It was like a perfect answer to insulation and stuff like that. And come to find out, many years later, people ended up getting such severe mesothelioma, which is a cancer of the pleura, right? So it's one of those things, right? And look at this pleural spaces here. You can see this thickening here, which could be indicative of of some sort of infection. But it's you can appreciate there as well too, some of these markings. Right, and again here, all this yellow area here is indicative of mesothelioma around in the pleural space. Some of it's super extensive. It goes all the way through. It even goes through the cavities, separating the upper and lower lobes. So it's very invasive. Silicosis, fairly common occupational hazard as well. Some of these acute inflammatory mediators are the same as they'll be in the rest of the body. IL-1, IL-8. What's the other one? I forget. IL-8, TNF, or I forget. One of those. And then, so good to know there for silicosis, eggshell calcification. That's a big one, a big buzzword to know for that. IL-1, IL-8, somebody help me out. It's gonna bother me. Anyway. All right, and then coal workers as well. Coal is carbon, so that's all they could really ask you about that. Anthrax, not super important, what right here. Okay, lower lobe tends to be asbestosis, upper lobe silicosis. Good differential there. Yeah. All right. And then coal workers, you would expect to get blackened lung. That makes sense because it's coal, it's carbon, so that's forms there. A lot of fibrosis and these occupational problems that form. Sarcoidosis is a weird thing. It's when you hear sarcoidosis, just think of granulomas. Okay, obviously caseating granulomas are in regards to tuberculosis. Non-caseating are the other granulomas, in my understanding. So any non-caseating granuloma it can form. So sarcoidosis that's what you think about. They tend to get these granulomas in the skin. I think they get them like all over, but in the skin and the lungs are most common. So keep that in mind. That could lead to restrictive problems. Type 4, which by definition is a delayed type site hypersensitivity, which means it's T-cell mediated, right? And okay. Again, these probably aren't as important as like the stuff with asthma, but fair game for a test. They put that in there you should be able to identify that this is sarcoidosis. You can see these little granulomas that are forming there. Non-caseating, there's no cheese in the middle, whatever that means. Right, here we go. Other organ systems, skin, eyes, parotid glands, spleen, liver, bone marrow, CNS. So yeah, they're all over, but I think the primary ones they talk about are in the skin and in the lungs. Okay, hypersensitivity pneumonitis, extrinsic allergic alveolitis and contrast. Okay, so sorry. Okay, so yeah, so this is going to be versus where asthma is a obstructive lung disease. This sort of hypersensitivity is going to lead to a restrictive lung disease. Okay, so excuse me. So you can see stuff like here, this farmer's lung, this hay. Again, these are occupational hazards that form as well. All these other things. So, and the reason they call this Monday morning blues is because throughout the week you get exposed to this stuff, and you go home on the weekend and you feel a little bit better. And as soon as you go back to work, you seem to get these symptoms again, difficulty breathing and stuff. And that's because you're exposed to the stuff that is causing the problem. Okay, so just keep this in mind that this is opposite asthma. This is a restrictive problem that forms. Type 3 and 4. So 3 is going to be those immune complexes that form, and then type 4, as we said, are the T cell delayed type formation. Okay. And then I'm trying to think. It's just for the record. We had our first, not the one we just took, the one we took before. It was cardio, pulmonary, renal, and heme all together. None of these crazy restrictive things came up. I think maybe the occupational hazards came up. A lot of the obstructive stuff came up, but like a lot of this is really nuanced. So like don't get bogged after this exam. Don't get too bogged down. I don't think STEP really considers this super important. Anyway, you want to keep these separate here. They're both caused by smoking, but there are some subtle differences here. So you can see that. Yeah, here. So just make sure you can identify the differences. Oops. Okay. Proteinosis. What is that? Defective granulocyte. Yeah, I don't know how super important this is. Sputum formation. I don't remember any questions ever coming up for this, but apparently it's accumulation of surfactant. So if anything, maybe just remember that, but this doesn't look familiar to me at all. Acute interstitial pneumonia, aggressive form of this interstitial lung disease, post upper respiratory tract infection. So of course, this URI is going to be acute, so you can correlate that with some sort of acute infection. And then, of course, pneumonia by itself is just fluid buildup in the alveoli, right? So if there's fluid in between the gradient between the oxygen and blood flow, of course, you're going to have problems oxygenating the blood, hypoxemia. So the degree of which you have fluid buildup there is going to determine how bad it is. So as you know now, there's so many causes of pneumonia, it can make your head spin. All right. What are these? All right. Now, pulmonary edema versus pneumonia, right? So when we talk about pneumonia, we're talking about fluid in the alveolar sacs, right? Pulmonary edema is more like interstitial development of fluid, right? So I mean, it's not black and white pneumonia. There's some that gets in the interstitial. Pulmonary edema will clog up the alveoli as well. But in a general sense, pulmonary edema, we're talking about the interstitial. Okay, so cardiogenic, anything that is going to increase the hydrostatic pressure, right? So any sort of pulmonary hypertension, it can lead to increased hydrostatic pressure. You're pushing, the hydrostatic pressure is pushing fluid out of the vessels into the interstitium. So by definition, that will lead to pneumonia. This is important to know. It's red right here, hemosiderin, which is iron, these macrophages, those are indicative of heart failure cells. So if you're getting this pulmonary edema, you're probably, it's secondary to some sort of left heart failure. and all of the blood is backing up, which is causing this increased hydrostatic pressure. And then you can have some non-cardiogenic, which means it's basically happening in the lungs, right? So it's acute respiratory distress syndrome. It could be a high altitude problem where you're having a lot of vasoconstriction to try to compensate. Decreased oncotic pressure, so any sort of liver problems, any sort of cirrhosis or anything like that, you're not making plasma proteins, particularly albumin. So remember that oncotic pressure holds fluid into the vessel. So if you don't have albumin, you can't hold fluid there. So the hydrostatic pressure wins and all of the fluid is going to leave, okay? Neurogenic problems that can happen as well. Head trauma, can throw things off as well. And of course, any sort of pulmonary embolism, you have a backlog of blood and that can cause increased hydrostatic pressure. So that could lead to pulmonary edema as well. Now, of course, we know a PE or pulmonary embolism or a thrombus that forms can be a huge issue there. Depending on the size, it could cause instant death. So some of the things, as you know by now, these hypercoagulability problems or any sort of immobility. They talk about an old guy that was on a plane for 5-6 hours. He gets up, he tries to get off the plane, he can't breathe anymore. He dies. What was the problem? He probably threw a clot to his lung, right? Okay, so that's an issue. Also, anybody that has an undiagnosed heart, actually no, those go to the brain, excuse me, never mind. All right. Right, look at this. This is called a saddle embolism. You literally blocked off blood flow to a large part of the bronchiole down there. So if anything, actually this is lodged in the main pulmonary artery bifurcation. So you're cutting off blood supply. So again, do we call this a shunt? Would this be a shunt? It's not, right? Remember we said in the beginning, a shunt when we talk about the lungs, a shunt is an air blockage. This is a blood blockage. So pulmonary embolism is not called a shunt. So just keep that in mind. Okay, so yeah, this is a huge problem. Right to left shunt, that's what I was going to say, but that would go to the systemic system, which would usually go to the brain. Okay. Yeah. All right. Anyway. Right, and this is characteristic. This is some sort of necrosis here in the lung that you can, this ischemic infarct that you can see here. So if they give you a picture of this, you should be able to identify that this is the lung. Pulmonary hypertension, again, in and of itself, it can lead to right heart failure because of the cor pulmonale. Stuff like chronic obstructive or even interstitial lung disease can lead to it. You're overworking the lungs, especially interstitial. You can't dilate the terminal bronchioles. Therefore, you're going to get a lot of pressure just because the blood's trying to work harder and to get oxygenation. So a lot of these airway problems can lead to problems with blood flow. See, this is saying a left or right shunt, which would make sense because then you could throw a clot to the lung because you go right to left. Okay. What did the other one say? Wait, no. Right to left goes to, sorry. No, because if it's in the left, if the clot goes from the right side to the left side, it goes to the systemic system. Is how you get. All right. I don't know what they're getting at. That's right? Right to left. Yeah. I don't know. Somebody could correct me if I'm wrong. What else? And again, if this looks familiar, this kind of looks like that hyaline arteriosclerosis that forms in the systemic system with chronic hypertension. So you could see this with this pulmonary hypertension as well that forms. Okay. Yeah. I don't remember this being very important either, but it's a primary immune problem that leads to coughing up blood. Maybe that leads to the anemia, and then you get pulmonary infiltrates as well. Oh, these include these. Okay, so these are going to be important. Good Pastures is something that comes up. It is a type 3 autoimmune problem. So you get these immune complexes that form in the lungs, but also more importantly in the kidneys, which I'll come across. Wait, sorry, it's type 2 hypersensitivity. Okay, I'm sorry. No, actually what happens is you have these autoantibodies that attach to the basement membrane. So it's actually just these antibodies that attach to the basement membrane, and that makes a complex. So it's type 2 hypersensitivity, these IgGs. They deposit in the kidneys, you end up getting glomerulonephritis, and they also deposit in the lungs. So when they talk about kidney and lung problems in an autoimmune disorder, they're typically talking about Good Pasture syndrome, pulmonary renal syndrome as well. Okay, so just keep in mind these IgGs, type 2 hypersensitivity, attach to the basement membrane and cause a lot of problems. Okay. So iron deposits there as well. Hemoptysis, edema, pulmonary infiltrates, right? That along with this glomerulonephritis that you key in on, there's some sort of deposits, right? So this Good Pasture syndrome that comes up. Now, Wagners, let me just go to this. I think nope, it must have been in cardio. There was like this nice little graph that had Wagners and Churg-Strauss and the other one all lined up. Anyway, okay, so we can talk about Wagners. Remember, it's C-ANCA. I believe it's the only one that we come across that's C-ANCA. Everything else is P-ANCA. So the C-ANCA attaches to this PR3-ANCA as well, but typically when they do testing, they check for the C-ANCA. So that would be Wagners. It's a glomerulonephritis. You tend to be, it's a small vesicle vasculitis as well. So that's what forms there. So you could see this in the lung and the upper respiratory tract. Okay, this pneumonitis that forms. And again, renal system is involved as well. So a good point here is to be able to differentiate. What are we talking about? Are we talking about Good Pasture syndrome, a pulmonary renal system, or are we talking about Wagners? Because symptomatically, they kind of present the same, right? You have difficulty breathing, you have difficulty with the renal system, hematuria, proteinuria. So they need to give you a little bit of extra information. Do we have C-ANCA there? Or do we have some sort of Good Pasture syndrome with these IgG complexes that form? Okay, I think with in the kidneys, they have these linear immunofluorescence is very characteristic of Good Pastures, because you could see all the IgGs that are lining the basement membrane. All right, good stuff. What time is it? Oof. All right, and then the lung cancers. Yeah, I mean, I think the most important thing is to know, the things that are common, right? So that's the things that are commonly tested. So knowing the differences there, the main thing that we still get tested on are these perineoplastic syndromes. So by all means, you need to know those. Like specific for squamous cell, you get parathyroid hormone or parathyroid-like or PRPTH, parathyroid related. Sorry.
Yes, PTH are parathyroid hormone related protein. PTHRP?
Yeah, it's PRPTH, I think. Parathyroid related PTH. Whatever, y'all know what we're talking about. Right, we'll get there in a second, but that's very characteristic. So it's one of those things like your patient comes in with hypercalcemia, they have renal stones, and you're like looking at their lungs, you're looking at their parathyroid gland, you don't see anything. It could be lung cancer. It's releasing this thing that looks just like PTH. So that's what's causing it, this ectopic PTH release or PTH related protein release that's forming. Small cell has a couple of things. You can get ACTH release from it. So you can get Cushing's-like syndromes, or it can actually release ADH, right? So you can get symptoms of, holding on to too much fluid, right? So hypervolemia and very concentrated urine. So you have to watch out for those. There are some other differences that form as well. small cell and squamous cell tend to be centralized. They have central foci, whereas adenocarcinoma tends to form on the outside of the lung. Okay, adenocarcinoma is less related. I don't think it's a clear-cut thing, but adenocarcinoma is less related to smoking, whereas squamous and small cell are highly related to a smoking history. Okay.
I have a question actually.
Yeah, what's up?
So when they're looking at the different like cancers, I see like the peripheral and central. So what's the peripheral and central like related to? Like what's it looking at?
Yeah. So sure, let me just so if you looked at the lung here, the central that they're talking about is centralized around the hilum, right? So small cell and squamous cell will be centralized around there. Okay, whereas adenocarcinoma and stuff like that, it will be peripherally located, right? Like you'd see them around there.
Oh, okay, that makes sense. Okay, thank you.
Yeah, no worries. All right, so now some of the things that could happen are, especially if you have some sort of apical tumor, you can get superior vena cava syndrome. All that is the tumor's compressing on the superior vena cava, which means like you can get it'll feel like numbness in the hand, but lack of blood flow to the hand. It can even press on the brachial plexus, I believe. But when they talk about superior vena cava syndrome, it basically means that it's constricting the blood flow to the extremity. And with Horner syndrome, you're basically pressing on the sympathetic nervous system or the sympathetic chain here that forms. So if you're pressing on that, you get unopposed parasympathetic. So the triad is ptosis, meaning the lid comes down, because remember there's a sympathetic component to keeping your lid up. Meiosis, constriction of the pupil, and anhidrosis. That's the triad. They have that anophthalmosis. What does that mean? Exophthalmos means your eyes stick out, so anophthosis must mean your eyes are kind of sunken in. I don't know why. The triad's this three. So if they give you that Horner syndrome, you could think of an apical tumor. Off the top of my head, I think that's probably the first thing you would think of in that situation. But again, it's a compression thing. Even recurrent laryngeal nerve crosses right around there. Oh wait, it's on the. Well, they both are, right? So there's two, but it's the left one's around the aorta. But I guess either way, in this situation, if you had some sort of compression from an apical tumor, you can get some sort of hoarseness as well. So yeah. Oh, here you go. This is the ulnar nerve compression as well. So then you can get numbness as well on the distal digits. Right, and here we go. I would definitely star this slide. I mean, questions for days on this stuff. So you could see, keep in mind, if you keep squamous as PTH, small cells, everything else, right? So you get this ACTH, again, you get Cushing's type syndromes, you get ADH, hyponatremia, right? Why is it hyponatremia? Because ADH brings back free water, okay? Those water channels, those in the kidney, in the collecting duct of the kidney. It's not aldosterone. Remember, aldosterone brings back sodium with water. So you're keeping yourself at equilibrium in that case. This is ADH is like a fail safe to just bring back free water. So if you have unopposed free water coming down, you're diluting your serum. So you're going to get hyponatremia as well. For whatever reason, kind of not exactly like the others, you can get Lambert-Eaton syndrome. Remember, we contrast Lambert-Eaton with myasthenia gravis. With myasthenia gravis, you get weakness with movement because of those acetylcholine autoantibodies. With Lambert-Eaton, you get autoantibodies against presynaptic calcium channels, okay? So they actually get better with movement. With repeated movement, you get a little bit of calcium each time, so it gets easier. So if you see some sort of problem like that, you can go think small cell. All right, lymph node metastasis. Sometimes I wonder, like, when I'm taking my notes and stuff, like, do you really need to focus on all this? A lot of times these lists don't really matter, but this is a pretty, since lung cancer is so prominent in the US, lymph node metastasis is really something you want to keep in mind. All right, so we can dive into it a little bit better. Non-smokers, most common primary lung tumor, actually that surprised me. Anyway, non-smokers metastasizes quickly, widely, and again, peripherally located, slow growing. Okay, kind of weird that it grows slowly, but it metastasizes so quickly. It usually doesn't go together. But anyway, just basic, keep it together, non-smoker, peripherally located. That should kind of key you in on that. Lipidic pattern, they like those words there. Sorry, this keeps coming up. You see it down here under adenocarcinoma, lipidic pattern. That's characteristic for that. Okay, so remember adenocarcinoma, we're talking glandular. Adeno means glands. Okay, so adenocarcinoma, glandular metastatic cancer or glandular cancer. Okay, I highlighted these earlier. I don't think they ever came up. All right, so squamous cell, centrally located. Men more than women, maybe because men tend to smoke more than women. I would assume that. Smoking history as well, central necrosis with cavitation. Okay, some of these key things. Keratin pearls. Any squamous cancer you have in the body, it is squamous, so it is going to form keratin pearls. Anytime you see keratin pearls, think squamous cancer. Keratinization, squamous cells, right? Skin cells, epithelial cells. All right, so these keratin pearls are what form. All right, neuroendocrine in origin, right? So neuroendocrine cells, which can lead to these formations of these perineoplastic syndromes as well. So it's even more convoluted than that, because typically we get questions with just ACTH and ADH, but it could even be gastrin, so you can get hyper secretion of acid in the stomach, or calcitonin, so you get hypocalcemia because calcitonin pushes calcium into the bone. But for all intents and purposes, as long as you remember ACTH and ADH, you should be fine. And again, lymph node spread. I highlighted this, but I don't think it ever came up. This, oh, you know what? Actually, take that back. I think we did see a picture like this. Maybe commit this one to memory. We did, didn't we? Yeah.
So make sure that you can distinguish the histo. Again, histo can be your friend in the path stuff, because they can also give you a patient presentation, give you the histo, not diagnose the patient, and then ask about the perineoplastic syndrome. So it's like, what would you likely see as a consequence of this cancer? So they can either put the small cell or the squamous cell, because those are the two that are big perineoplastic ones. And then you're going to have to pick, increased calcium or something like that. So make sure that you can connect those two.
Right, and they could even take it a step further and say the patient comes in with kidney stones. Why do they have kidney stones? Calcium-based kidney stones. Well, because they have hypercalcemia. Why do they have that? If they're their normal PTH is, or their actual pituitary PTH is normal, you need to be thinking of an ectopic source. Now, you should be able to look at this picture and say, this looks like cancer, right? Look at these cells. This is very highly mitotic cells. Look at the nucleus to cytoplasm ratio. Look how many cells they are. Like, there's a lot going on here, and that's problematic. So again, that could be a giveaway for, if nothing else, than just cancer in and of itself. All right, large cell, they don't really talk about this one too much. Those are the three ones that we already covered, are what they really like to talk about. Then carcinoid tumors, anytime you think carcinoid, you think serotonin, right? What's the byproduct of serotonin? 5-HIAA in the urine. It's too much calcitonin, okay? That would make sense. Sorry, I said calcitonin. Too much serotonin, right? If you get 5-HIAA in the urine, that's the byproduct. Neuroendocrine, that makes sense because it's serotonin. Kalicki cells, I would know that as well. Okay, so carcinoid tumors. How would this patient present? Well, with serotonin syndrome, right? Flushing, things like that, tachycardia and such, right? Again, these cells aren't as bad as the other ones, but look how big these nuclei are. They're huge compared to the cells. So looks like a lot of stuff's going on. These do tend to form higher up in the bronchus, okay? So if anything, when you're thinking of, where everything falls, I put them pretty midline, not midline, but like midway through in the bronchus area, bronchi. All right, I don't think they really got into the differences here. As long as you know that serotonin is the problem, should be there. Flushes, cyanosis. Oh, diarrhea is the other big one with serotonin that you see. So, yeah, definitely know that. And then look at this. This is all. So this is the actual lung right here. This is just that little layer of pleura. Look how extensive it is, right? This is all mesothelioma. Look how, I mean, that's insane. Right, so risk factor asbestosis. But if they talk about some sort of pleural cancer, I would lean towards asbestosis for sure. Hamartoma, these are just nodules that form, not super important. Did they say? No, okay, I won't get into it. All right. No, I think you're good there. And then again, this is, again, as I said, I'm not really a chart person, but when it comes to differentiating things such as these important, these are where the test questions come from, okay? Definitely know the perineoplastic syndrome. All right, what's next? Oh God. And for the record, so y'all know, this will make y'all feel better. Our BSCEs, there have been no pharm on them whatsoever. Like, I don't know about Lindsay, but like, I don't even study pharm too much for these things.
Neither do I.
unless I'm doing practice questions and they come up, like, I'm not making an effort to go back through these lectures because they just haven't come up. Like your BSc 1, I don't think y'all had it either. But yeah, so far in term 5, like it's been, not that they've been easy, but they've been not a lot of pharm.
Sorry, Brady, can you, before we move to pharmacology, can you go over the hypersensitivity pneumonitis again?
Yeah, sure. What lecture
I was just
that?
confused because it's lecture 4?
I think
or
the
RHS 7.
All right, so like pulmonary 4. I think the big difference there is just to be able to differentiate that it seems just like asthma, but it is a restrictive lung disease versus whereas prototypical atopic asthma is going to be an obstructive lung disease. Here we go. Yeah. So extrinsic, yeah. So it falls under a restrictive lung disease, but it still is a hypersensitivity that forms there. But other than that, it's very similar.
Wouldn't you be allergic, for example, to mold? So wouldn't you have asthma then? No. Does that make sense?
I don't think it's necessarily like an abnormal response. Like I think it's like like it said, like prolonged exposure to something. So it's not like you were predisposed to it, like you have some sort of like genetic problem with certain, like with pollen, right? Which would be atopic or an IgE response. This is like some sort of prolonged exposure, like an occupational hazard to something. So it forms over time. Like it could literally happen to anyone. It's not like it happens as a child just because you were genetically predisposed to it. So it has a lot that goes similar to normal asthma, but this is a restrictive lung disease that happens over time, typically due to occupational exposure. Yeah.
Okay, thanks.
And like it says here, like it still falls on, so like whereas atopic asthma falls under a type 1 IgA response, this will be a type 3 and type 4. So it takes time, especially this type 4, this delayed type, for your T cells to kind of get aggravated with the fact that like you're around mold all the time, right? So eventually they just you get a response to it as well. So IgG response.
Okay, thank you.
Yeah, no worries. All right, so did we need to know these? Yeah, we did, didn't we, Lindsay? The differences.
Yeah, I think we maybe had one question on what like diagnosed a specific asthma severity in this patient.
I think, I think maybe this determines the treatment regimen, right? Is that right? Y'all probably know better than us at this point. But yeah, so bronchodilators, asthma, y'all have come across these already. But any sort of beta 2 agonist, bronchodilate, by all means, don't give these people beta blockers. It's a good way to lose your license. But yeah, so the short acting versus long acting, I would definitely commit these to memory. Albuterol being the first line for most, and then salmeterol as well is used pretty often. You need to know which ones are short and long. I think it's been a while, but I think at the end of this, they give you a chart that shows you when to use what. Important, these beta 2s, remember, From first aid, alpha 1, alpha 2, beta 1, beta 2 is GISS. No, yeah, well, QISS, KISS. So beta 2 falls under S. So it's GS, simulates adenylyl cyclase, and CAMP, all that stuff from way back. Short acting. So we won't go through all this stuff. I mean, you know, with the drug regimens or with the drugs, you kind of just have to have a definition of how they work. So this should be pretty straightforward. Anticholinergics, if you're, you know, anything cholinergic is going to compress or constrict. So anticholinergics will help to dilate. So ipratropium as well can be used if somebody has some sort of some sort of not extensive, but exaggerated response to some sort of beta 2 agonist, you could do ipratropium. I'm sure there's a couple of asthmatics in here that could teach this a lot better than me. So, but I'll do my best. Yeah, always adverse effects are going to be important as well. Yeah, methylxanthine, this is theophylline is kind of like caffeine. They don't really talk about that too much. Right, and of course, corticosteroids can be used as well. The problem with those using corticosteroids for long-term treatment is not ideal, because it messes with the kidneys and all that stuff with your cortisol, among other things. Yeah. So, yeah, so as we go on, I mean, like, I guess fair game, but some of the drugs you've never heard of before, I would literally just know like what they do and maybe just a little definition. Inhibiting mast cell degranulation, fine, that you should be able to answer the questions with that. Omalizumab, I think I've seen commercials for this actually. Prevents binding to IgE, makes sense for asthmatics as well. And then here's our leukotrienes. They like these as well. So xylutine is that inhibitor. This 5-lipoxygenase makes actually leukotrienes. It's that last step in leukotriene synthesis, I believe. And then you also have these leukotriene receptors. Of course, leukotrienes come from the arachidonic acid pathway. They're going to cause bronchoconstriction. So if you can block these, it'll help with keep the airways open. What is this? That sounds familiar. What happened here? NSAID exacerbated respiratory disease. Oh, you know what? Oh, that's what happens, right? So if you give NSAIDs and you block the pathway of making COX, everything gets shunted to making leukotrienes. So therefore you get bronchoconstriction. So just keep that in mind, right? So if you're going to block the pathway to make prostaglandins, in that arachidonic acid pathway, everything's got to go somewhere. So you end up making leukotrienes. So people that are predisposed to asthma and stuff, you need to be aware of this nerd effect. All right, here it is. Yeah, unfortunately, you need to know this, right? So you have to take the first one and see, they're going to give you the symptoms of this, 2 asthma attacks a week, wakes up at night with asthma. So you need to be able to take that, and see where they fall in this category, and then you can decide what to give them. Okay, so that's fair game for your test questions. What else? Right, of course, COPD management, first thing you want to give is the patient oxygen, right? Even, if it's bad enough, they could, they send them with at-home oxygen. If in the hospital, by all means, you can just hook them up. Bronchodilators as well can help with these patients to kind of keep those airways open so they could get that air out. Inhaled corticosteroids does not slow the progression of COPD. I mean, that makes sense. But you can improve lung function, by kind of keeping those airways open. N-acetylcysteine, that's in Mucinex, I believe. And then that can help with breaking down mucus for chronic bronchitis patients, probably even asthmatics if need be, or if you have some sort of URI. And then, of course, antibiotics. So this is all fair game too. we had to correct this. I don't know if y'all had to too, but make sure that's right in your notes if you have it. But yeah, you need to know these as well, what grouping they fall under. Right, same stuff. Rhinitis, glucocorticoid spray, the histamines, any of these fall. That should make sense. All right, then oral antihistamines as well should help. H1 receptors, right? Remember, H2s are in the stomach. H1s are going to help with that that response, that that allergy type response, or that you know what I mean. And then decongestants, either alpha adrenergic agonists, right? So they're going to cause vasoconstriction, so that'll help dry up your nose. Cough, codeine, and dextromethorphan as well, right? Codeine will help with the pain, and dextromethorphan as well with the cough, that cough reflex. Correct. I think all I have left are the respiratory infections. Did y'all not? Did I miss something? Didn't y'all do? Did y'all do a lecture on what's it called? Chemotherapy drugs?
Yes, we did. Yeah.
That was week 4 for us. Yeah.
This was it. This.
There was 3 lectures for it.
But it included the lung cancers. Okay. How about when
second lecture? I think second
Okay.
and third kind of included them.
Okay, so Lindsay, when you do the red blood cell stuff after you're done,
Yeah.
I'll go back and do the chemotherapy regimens. Those three
Yeah.
lectures, right, guys? Yes.
So
Okay.
it's really just the anemias. That's the red blood cell stuff.
Yeah, and the leukemias and all that. Yeah. Okay. Yeah, I'll do the chemo stuff after Lindsay's done. All right. So let's quickly go through this. As we know, everything can cause pneumonia, right? It could be viral, bacterial. Being able to differentiate it is the problem. Usually, you just give them a cough in a cup. Get some sputum sample, and you can isolate the bug of interest, right? So on the test questions, you need to know what's gram-negative and all that nonsense. I know it's a pain. I still don't know those as well as I'd like, but yeah. So I think this was just intro. Yeah, of course, obviously, if you have pre-existing lung conditions or some sort of immunosuppression, which is a big testable topic, you're predisposed to different sorts of bugs, right? Let's see, I want to get to the actual, okay, what's going on? Clear discharge, typically clear means viral, right? Clear discharge. So this kid's got rhinitis. Let's see, so being able to differentiate rhinovirus, typically they talk about that with kids, right? They get that infection around the daycare center. It's usually, it's self-limiting. Typical viral infections are self-limiting in and of themselves, but it's highly contagious. What do you need to know from this? I think what I wrote up here is what's important. Winter, you can get coronavirus and these influenza virus. Summer is typically rhinovirus, enterovirus, and adeno is year long. It's not like you 100% need to know it to answer some of these questions, but like it's in the stem, it's like it's the middle of summer. And so you could kind of isolate like what you're talking about. So keep in mind this rhinovirus, summer camps, things like that are problematic. All right, and you can see here, so knowing this stuff, unfortunately, is important. Single strand, I think they may all be the same for this. Don't quote me, we'll get there. So single-stranded falls in, RNA falls into class 4. And then knowing some of these different characteristics of it, icosahedral, it's going to be important as well. Spring, summer, fall, yeah. So crowded areas, daycare settings, super important. Yeah, secondary bacterial infections. Anytime you have something that predisposes you to be even mildly immunosuppressed can lead to something bigger. So a lot of times they'll start out with a viral infection and end up with full-blown bacterial pneumonia, right? Okay, so. And this is another thing, I know y'all are y'all are getting to the point with like all these virulence factors that come up. How many do you need to know? Yeah, I don't have a good answer for you. I don't like dive down too deeply into knowing all these virulence factors, but some of them that are important in diagnosis, or like that make the bacteria or virus super specific to them, like I'll make note of that. But a lot of these kind of overlap with each other. And again, if it overlaps, it's very hard to be tested. Okay, what's going on with this guy? And again, remember, these viral infections tend to be very quick onset, right? That happened, what was the first one? 24 hours. Okay, so let's see what's going on here. 12 to 14 hours, right? So quick, right? Where the bacteria has to get seeded and it takes days to figure out what's going on. But these got rhinopharyngitis. So whereas rhinovirus is very, very nasally, this is rhinopharyngitis. This again, okay, so both rhino and this coronavirus definitely falls under single-stranded, so they're both group 4, so that's good. This one's envelope versus icosahedral. And then we go into this. Fair question, are even any of the COVID questions on the exam, are they still all experimental? Because they just started writing these questions. We joke about that, we don't know, but it's getting to the point where they probably have enough data on them. So I guess they're fair game. Now you can contrast this with rhinovirus because you see this in the wintertime. But other than that, it's pretty much indistinguishable from rhinovirus, right? All right, and then the third one is adenovirus, where this one's double-stranded DNA, so it falls under class 1, non-enveloped. So again, like I said with the virulence factors, I don't like learn them all, but this is something that's very specific to this attachment protein has this penton base. I don't even know what that means, but I know that it's specific to it, right? It helps to attach. And then what does it mean to say that immunity is transient? It means you can have it and it's not something that your body's going to be able to fight off from then on, like some other infections, right? It has different variations to it. So, there's no good vaccine for it or anything like that. Happens throughout the year. Big thing that differentiates it there, it can cause pink eye. Okay, so super virulent, highly infectious. Oh, it does say there is a vaccine. Okay, well, I mean, transient immunity just means you're not going to form a strong defense against it because there's so much variation there, but it does seem to say that. I don't know how well this vaccine works, but anyway, yeah, so pink eye is going to be the thing. So some sort of conjunctivitis or eye infection, keep that in mind, and those will keep those separate. What else? Yeah, pink eye, there you go, right. All right, and that's it. So again, and that's my thought process when I go through these things. I'm like, we're talking about 3 major viral infections, right? How can I differentiate these on the test, right? Rhino and coronavirus, very similar, different time frames. Coronavirus also include the pharyngitis, adenovirus, double-stranded, DNA, add the pink eye to it, that pentose-based thing. That's pretty much where I land when I do a lot of these things to be able to differentiate them for testing purposes. All right, bacterial infection. All right, give us a time frame. Thick yellow, green tends to be, and the thickness of it tends to be more bacterial. 3 days, so we're going past the 1 day, that 24-hour period. Look how bad this is. That's the sinus, right? When you ever get that sinus pressure right there, you can think about this guy. That's real bad, okay? Maxillary sinus. All right, so the big ones is strep pneumo, Haemophilus, Marksella as well, chronic problems, Staph aureus. But typically we talk about strep pneumo when we it's like our first thought when we do these. Respiratory droplets, you know that. And then, yeah, so a good thing that's applicable is the reason children tend to get ear infection, acute otitis media, is the angle of the eustachian tube. Theirs, I believe, is more horizontal, so it lets it's easier to have transmission there. So that's why they're prone to that. And here we go. So viral upper respiratory tracts under 7 days. Bacterial tend to be longer, right? That's over 7 days. tenderness of the face, just because you have that thick mucus buildup. Okay, so these, again, when you're doing these questions, the first thing you should ask yourself, are we going viral or are we going bacterial, right? Even clinically, right? Are we kind of just send them home, which we should do if there's a viral infection, or we're going to put them on antibiotics, right? Okay, then acute otitis media, I believe you're thinking of Staph aureus is the first thing there, and you can see through the eustachian tube right here. Yeah, right. You can see that going on here. And this thing MRSA is the most common cause. So yeah, staph, bad staph. All right, so this is a great slide to be able to differentiate these, because they're going to tell you kid comes in, has some sort of pneumonia or whatnot, and the alpha hemolytic, which is a partial hemolysis, okay? So if they say it's alpha hemolytic, that should lead you straight to strep pneumo. It's the most common cause of sinusitis, otitis media, pneumonia, and even meningitis, okay? Of the streptococci, okay? So know that. And then, you know, strep pyogenes is that beta hemolytic one. Pharyngitis is the big thing there. Strep alligatiae, I think they just refer to that as group B strep. It's the only one that falls into group B strep. Common cause of neonatal disease. I think the vaginal flora sometimes picks this up. So the neonates are predisposed to this. In utero, it can lead to meningitis and stuff. All right, so strep pneumo, you know by now, gram-positive diplococci, has that big polysaccharide capsule. Remember that's a problem for people that don't have a spleen. Shin, so strep, Haemophilus influenza, and Neisseria, big things there. So you need to know that would be a virulence factor. I would commit to memory, polysaccharide capsule, and that's how they make the vaccines. Again, alpha hemolytic, partial hemolysis, pneumococcus, right? Pneumonia formed by the cocci. Now, again, very important, optogen, I don't know how to say that, optogen sensitive versus the Viridans strep, which are the ones you find in your dental procedures, okay? That causes endocarditis. A lot of times when I write these out, I don't know about you guys, I don't necessarily write the negative things. I just write the things that they're positive for. So it keeps my notes a little bit more concise. So I would write that down, and even maybe biosoluble as well. All right, and then it goes into the process of how this all forms. You would expect ILA, tumor necrosis factor as well. Pneumolysin, maybe that's important to know as well. All right, yeah, so it'll start asymptomatically. It'll kind of just brew there. This biofilm will form, and then, or eventually, and then you can become symptomatic. IgA protease is another one that's very important. Protease, meaning it cleaves proteins. It'll cleave these mucosal IgAs. It's a problem because you don't get an antibody response to it if you're cleaving all the IgAs. So that's another virulence factor I would keep in mind there. Pneumolysin is another one as well, right? An exotoxin. So it's cytotoxic to the cells. So that's always problematic. Decreases your neutrophils and their ability to fight the infection. Capsule there as well. We kind of talked about that. Problems with people that don't have a spleen. So you're thinking people with sickle cell and stuff like that. All right, what else? H flu. Yeah, not as common. Facultative anaerobe, gram-negative now. Coccobacilli, you can see that there. Can cause kind of the same type of symptoms as well. Type B is the one we worry about. That is the one that the HIV vaccine is made against, okay? So that's the one that they're really worried about here. Big thing here, it grows on chocolate agar, but you need to know even a further step there that on the chocolate agar too, because a lot of stuff will grow on chocolate agar, I believe. And so what they do is they put a factor 5 and factor 10, this NAD and hymin. I believe we had a question on this. So this will help to differentiate it specifically for H flu because they need both of these. So I would definitely make sure you know that. All right, what else? So again, these are some of those virulence factors. It also, you know, this IgA protease there as well. It's encapsulated, just protective factor. All right, what else? Epiglottitis, right? That's very specific for this. Okay, so you see this right here, the thumb sign, You see this lighter area looks like a thumb. It's epiglottitis. This tripod, this is how this child is able to breathe a little bit better by like extending its throat, opening its larynx. Right. So again, any sort of epiglottitis, you should think Haemophilus influenza type B. All right, a little bit less important, Varicella, gram-negative Diplococcus, children, yeah. Grows on blood auger and chocolate auger. Oh, hockey puck. Yeah, that may be important to know. Yeah, I think they said something about that, actually. Okay, what else? Vaccines that are to be known for it. And again, vaccine protocols, typically 7 to 10 days, up to 14 if necessary. All right, so what's next? All right, mumps, right? First thing you should think of is mumps is parotiditis, right? The parotid gland gets infected. Also orchitis, they get testicular inflammation and infection as well. So these will be single-stranded negative RNA, right? So that falls under type class 5. Big thing, colleges, crowded conditions as well. Right, so parotiditis is the big thing they talk about, this bull neck, swelling of the parotid gland. Orchitis as well. And of course, big thing there, they need to tell you in the stem, if they tell you the person hasn't been vaccinated, if they're coming from a foreign country, you can assume they may not be vaccinated as well. So then you're starting to think of the things that are vaccine prevalent. All right. Pain, look at this high fever. Here's another differential. Typically, viral infections give you a low-grade fever. Bacterial infections, you'll get these high-grade fevers like 104. So that's another way to differentiate other than the time frame. All right, yeah, and you can see this here. Now, when it comes to pharyngitis, right, that has a fast onset for these bacterial infections, whereas a slower onset. So it's a little bit different there when you think of it. But again, here's this high-grade fever as well, and it's more of a thicker discharge. Right, and now we're starting to think of strep pyogenes, which is your classic strep throat. Beta hemolytic means complete hemolysis on the blood auger. It falls under group A strep. Pharyngitis is the big one, and you've learned stuff like rheumatic fever and acute glomerulonephritis as well, streptococcal glomerulonephritis. Right, beta hemolysis, it'll clear the whole area out, okay? Yeah, streptolysin. Right, absence of a cough is suggestive of bacterial, okay? So if there's a cough, you could think of a viral infection. Again, these are more, the reason they put these in the stems of the question is because you're gonna see so many patients with this. So, you know, these are the things that are gonna help you differentiate things. All right, chronic tonsillitis. All right, strawberry tongue. Yeah, that is a complication. Strawberry tongue that forms. The sandpaper rash as well. This is the scarlet fever that forms. This is a sequelae to the strep infection. You can see that here, the strawberry tongue, little bumps on it, and the sandpaper rash as well. Okay, and then you learned about acute rheumatic fever. This is that molecular mimicry, right? So you end up getting, after this, you can get rheumatic heart disease. It shows molecular mimicry, which means when you check for it, there isn't an active infection in the blood, right? It's your actual immune system is trying to fight cells that it assumes were strep pyogeny cells, but right, that's the whole concept of molecular mimicry. Type 2 hypersensitivity, right? Again, you're making autoantibodies that you think you're fighting, but you're actually fighting yourself. And then, of course, it can lead to a PCGN, right? Post-streptococcal glomerulonephritis. Again, they have to tell you the patient has kidney problems, but they have to tell you they're coming back from some sort of recent pharyngitis or throat infection like 2 weeks ago. Okay, so that'll lead you to that. It's pretty much self-limiting. It'll fix itself up. All right, diphtheria, right? Gram-positive. Yeah, I don't know how important that is. Let's see, yeah, and it makes these toxins, right? These AB toxins. The big thing about that, the buzzword you want to remember for diphtheria is this pseudomembrane formation, okay? It forms in the neck, and it's because of these toxins that form. It's not technically invasive, right? That's why it forms this membrane. But if that membrane ruptures, all the toxins get flushed into your system. So that's the big thing there. But knowing that it's non-invasive is a good thing to know, because it kind of goes together. You could say non-invasive, which is why it forms the pseudomembrane. What's that made of? These toxins, right? So that's how that works as well, right? And it goes through the process of how it, the toxins formed. And you could see that there, the nasty little thing. It's full of toxins, right? So if it ruptures, it's problematic. All right, what else? Special auger for it, Tinsdale auger, or even knowing sodium thiosulfate as well, hydrogen sulfide. Yeah, I would know that. Don't think this came up, but it's just another test that they could use. If it's toxigenic, I guess they form these precipitates form. Toxin plus antitoxin form these precipitates. Right, okay. And that's all I got. All right. Any questions?